Hi, I'm Dr. Terry Pinson, and I'm going to discuss the surgical treatment for obesity. We use a laparoscopic approach. And what is a laparoscopic approach? We're operating with a video camera. We make these small incisions and place these little trocars and insufflate the abdomen and actually do the operation with small instruments, the exact same operation that we used to do with a large incision. The advantage of a laparoscopic approach is that it's typically easier on the patients. There can be a shorter hospital stay. You're up moving much more quickly after the operation. You get back to work often very quickly. Because we don't have a large incision, there are much fewer wound complications, less infection, fewer hernias that develop after the operation. So for the patient, there's less pain and faster recovery. From the surgical perspective, we have a magnified view of the anatomy. We're able to see the position of the anatomy as normal position. There are fewer respiratory and cardiac complications. The operations that we do, laparoscopic Roux-en-Y gastric bypass. What is this operation? If you look at the picture, you'll see the esophagus and then the stomach. What we do with this operation is we divide the stomach, making it about the size of my thumb. We then divide the small bowel, connect it together, bringing up a limb of small bowel and connect it to the small gastric pouch. We make the opening between the gastric pouch and the small bowel about the size of my little finger. So what happens? Well, the food bolus comes down through the esophagus into the small gastric pouch, which is about the size of my thumb. So it fills full very quickly. Then the food bolus slowly goes through this limb of small bowel, and then the gastric juices, bile juice, and pancreatic juices mix with the food bolus about 6 feet farther downstream. So there's less opportunity and course of absorption in the small bowel. This was one of the most frequently performed bariatric procedures in the United States. It's been done first in 1967. It's been done laparoscopically since 1993. We've been doing it here laparoscopically since 2001. There's about 50 to 80% excess body weight loss at 14-year follow-up. Now, gastric bypass has advantages. There's rapid initial weight loss. Most patients are going to lose their weight between 12 and 18 months. We're able to do it laparoscopically, and we have the longest experience in the United States. Disadvantages. We have to divide the stomach and the small bowel, and we have anastomosis, so it's a much more complicated operation. Because we bypass a portion of the digestive tract, there can be malabsorption related to these areas that we bypassed. Gastric bypass is a more complex operation which can lead to more postoperative complications early and in the late postoperative period. Laparoscopic adjustable gastric band. What is this operation? Well, the lap band is this elastic band with a little balloon on the inside of it. We put the band system just distal to where the esophagus, the swallowing tube, and stomach come together, making your stomach about the size of my thumb. Inside this elastic band is a balloon that connects to a tube to a port that fits up under the fatty tissues, usually in your left upper abdomen. What we can do is introduce a little needle into the port in the clinic and add fluid, and it narrows or makes the opening, controls the opening to the small gastric pouch. So you feel full faster, longer, and a lot less food is more satisfying. It's critical that we can adjust this band. Now at the bottom we have process can be reversed. What does that mean? If something happens, we can take the band system out. Not if you lose your weight. If you lose your weight and say, I want the band out, generally you'll gain all your weight back. Now, laparoscopic adjustable gastric band. It's been around since June 2001 when the FDA approved it. February of 2011, the FDA approved the use in laparoscopic adjustable gastric band in patients with a body mass index of 30 to 34 with at least one comorbidity. There are more than 850,000 laparoscopic adjustable gastric bands that have been placed worldwide. Lap bands. The advantage is least invasive of all the bariatric procedures. There's no stomach stapling or dividing. It's adjustable. We can do the adjustments in the office, so patients feel full on less food. It has the lowest operative complication rate, lowest mortality risk, and lowest malnutrition risk. Disadvantages, slower initial weight loss. Patients have to come back on a regular basis for optimal results. It does not always decrease hunger. And some patients may not be candidates based on prior operative intervention in this area. Now, vertical sleeve gastrectomy, laparoscopic vertical sleeve gastrectomy. This is the most common operation that we do here at North Mississippi Medical Center. With this operation, as you see in the picture, the esophagus, you come down, then you have the stomach. What we do with this operation, we put a little tube down about the size of my little finger, goes down through the esophagus, down through the inside portion of the stomach, down through the pylorus. On the outside edge of that, we then divide and take out that part of your stomach. And you look at it and say, well, gosh, what does it do? It limits how much you can eat, right? Well, that's part of it. But there are also many GI hormones that live in that part of the stomach. So when you take it out, there's less desire and less quest for food. So it's a metabolic operation. things about the operation. We haven't changed your GI anatomy. The food and nutrient bolus, even though much smaller, will go through the exact same course as it does today. So there's less malabsorption than other procedures. There's about a 70% excess weight loss at 2-year follow-up. This is a video demonstrating the laparoscopic vertical sleeve gastrectomy. These are the small incisions we make, and then we carefully place the trocars. Then we insufflate the abdomen with CO2. The instruments that we use are about the size of a yellow writing pencil, and the video camera is about the size of a child's pencil. Inside, what we see is the esophagus, the swallowing tube, and then the stomach. In this video, you will see the food and nutrient bolus demonstrated in the blue is coming down into the stomach, and the stomach's a reservoir, so it churns this food around and mixes it with some gastric acid to help break down the food, and then the food goes down through the course of the small bowel where it's absorbed. With this operation, we put a little tube down along the inside of the stomach, down through the pylorus on the outside edge that we then divide, as you can see in the picture, and then take out that part of the stomach. Now, in the video, you will see momentarily, the food and nutrient bolus, much smaller now, will go through the exact same course, down through the esophagus, down through the pylorus, into the small bowel where absorption will occur. Just like as it did, but your stomach now is much smaller. Complications of bariatric surgery. Even though we're doing these operations laparoscopically, they're still all real operations. Every time we touch somebody, we worry about infection, we worry about bleeding. We do everything we can to minimize the risk. There are some unique things with each of the different operations. Dysphagia or difficulty swallowing is more common in those patients with bands if they get too tight. They may have distension of the stomach is more common. The lower gastric remnant may become distended after Roux-en-Y gastric bypass, and it may require operative intervention. Esophageal dilatation, more common process will be if the band became too tight. Abscess or ulcer can occur just like it can in a patient today who has not had a bariatric procedure. Now, the idea behind all the bariatric procedures is that you eat 3 small regular meals a day. There can be chronic nutritional problems such as protein, vitamin, and mineral deficiencies if you do not adhere to that regimen. There can be nausea and vomiting, gas pain. Unique to the band is the band is actually a mechanical device. So we have to access the port with a needle, and you could have a port or tube problem. If that happened, we could change the port or tube without changing the whole band system. A band slippage is where the stomach actually herniates up under the band. If that happened, we could have to take the band system out. Band erosion occurs less than 1% of the time, but if that happened, we could have to take the whole band system out. Generally, if that happens, you would not preclude you from an additional bariatric procedure in the future. They're all real operations with risk associated with anesthesia, etc. Medical comorbidities. The great thing after an operation, one of the most important parts of bariatric procedure, is improvement of medical comorbidities. The great thing is with type 2 diabetes, it's improved the majority of patients after a bariatric procedure with significant weight loss. Hypertension improved or even resolved in many patients after a bariatric procedure with significant weight loss. Cardiac function. What happens to your heart when you lose 100 pounds? It says thank you. Thank you. You're able to go do more things. Your risk of cardiac issues are improved significantly as these other medical conditions are improved as well. Osteoarthritis, your knees, your back. What happens when you lose 100 pounds? They each thank you. Sleep apnea. It will go away in about 70% of the patients to 85% of the patients with significant weight loss. Stress incontinence is improved in the majority of patients with significant weight loss. Reflux improved in the majority of patients with significant weight loss. Hypercholesterolemia, again, high cholesterol levels improved in those patients who have success with a bariatric procedure. Key points to remember. Diet and exercise only work for about 1 in 300 people. If you've lost weight on a dietary regimen and then you went back to your regular dietary regimen, what happens? You gain weight. That's what most people do. Surgery is safe and effective. Surgery is not the easy way out. There are many expenses and hassles, and it's an effort. It's a tool that's utilized short-term and long-term to lose weight and control your medical conditions. Reduction or improvement of comorbidities, that is the most important part of the post-operative aspect of a bariatric procedure. Bariatric surgery provides a safe and effective way to lose weight and have long-term results with improved quality of life. The benefits of surgery outweigh the risk of staying morbidly obese. Each of the procedures are reversible except for laparoscopic vertical sleeve gastrectomy, but it's very rare that we reverse a bariatric procedure. In summary, morbid obesity is an epidemic today. Surgery is the only effective tool for those patients who battle morbid obesity. Laparoscopic techniques reduce complications and speed recovery. Multiple comorbidities are reduced or resolved in the majority of patients. Surgery for obesity is a life-changing event, allowing patients to live again.